نسعد النهارده باستقبال الدكتور كريم إبراهيم في زيارته لجامعة العالمين الدولية. الدكتور كريم إبراهيم is a senior clinical pharmacist specializing in hematology and bone marrow transplantation في الكانسر انستيتيوت في ولاية نيو ساوث ويلز في أستراليا. وعنده أكثر من 20 سنة خبرة في ممارسة الصيدلة، من ضمنهم 10 سنين من leadership expertise في مانجنج رعاية المرضى اللي عندهم هيماتولوجيكال وانكولوجيكال malignancies الأورام. دكتور كريم حصل على الدكتوراه بتاعته من جامعة كوينزلاند في 2013. المين areas of interest، الأماكن اللي بيشتغل عليها بيركز عليها supportive care in bone marrow transplantation, oncology, infectious disease, HIV related malignancies. He also had a passion for teaching للتدريس ومنتورنج and is currently a conjoint senior lecturer في St. Vincent Clinical School في University of New South Wales بسيدني بأستراليا. هو أيضا senior pharmacist evaluator في Therapeutic Goods Administration الجهة الأسترالية المناظرة لل FDA بأستراليا، وهي الأستراليا طبعا Medicine and Therapeutic Regulatory Agency. ودكتور كريم ان شاء الله بيستعد لبدء منصب جديد في الكانسر ايجنسي في كانسر انستيتيوت بنيو ساوث ويلز. ساعتها ان شاء الله هيبقى له دور ان شاء الله في مساعده الناس بعد الاطلاع على الجايد لاينز، تنفيذ الجايد لاينز دي into practice in a standardized manner. هنبدأ بالشيرنج السكرين وينورنا ان شاء الله دلوقتي دكتور كريم. اتفضل يا دكتور.
Thank you, Dr. Muhammad, and thank you for Alamein International University for the kind invitation. شكرا على دكتور محمد وجامعة العالمين الدولية على الاستضافة. My presentation today will be about introduction to pharmaceutical care. ازاي احنا نقدر ناخد بالنا من مرضى السرطان وأمراض الدم، وخصوصا مرضى Hematopoietic Stem Cell Transplantation. Those patients undergoing transplant ومرضى زرع النخاع. وهنركز النهارده in particular على مرضى زرع النخاع، بس هنحاول برضو نعمل إبراز دور الصيدلي في رعاية مرضى السرطان وبخصوصا hematology and bone marrow transplant. So this presentation is mainly for pharmacists who are practicing and pharmacists who are working in the cancer field, but I'll try to make it also as applicable as possible. Particularly, I know there are students and some other practitioners who might be watching the presentation. I'm just having a little bit of trouble going through. Here it is. Okay. So we'll start first with the aims and objectives. So my main aim from this presentation is to provide an overview of the role of the pharmacist in cancer care and hematopoietic stem cell transplantation. هحاول في خلال المحاضرة دي إن أنا أركز على دور الصيدلي في الكانسر كير وفي رعاية مرضى زرع النخاع. Objectives: we'll discuss important terminology in cancer care and hematopoietic stem cell transplantation. We'll try to understand how the transplant is performed, discuss the different types of transplant, also highlight graft versus host as a major complication of transplant, discuss the management of graft versus host disease, and discuss infection prophylaxis and other supportive care strategies in patients receiving cancer treatments. So the role of the pharmacist in cancer care and transplant. The first is obviously provide advice regarding the correct dose. Sorry. Provide advice regarding correct agent choice, dose, and treatment duration. Provision of drug information to patients, their families, including adherence assessment. Provide education to other healthcare professionals regarding the administration, dosing, and side effects of chemotherapy, immunotherapy, and radiotherapy. Checking for drug interactions, therapeutic drug monitoring, assessing the need for dose modifications, particularly in renal and hepatic impairment, and monitoring for cost effectiveness, provide education and recommendations regarding supportive care, particularly the use of antibiotics, antiemetics, analgesics, corticosteroids, and antihistamines, perform policy, quality, and research duties. Whenever I start any presentation, I always want to highlight the role of the pharmacists, particularly the role of cancer pharmacists in the care of patients. And this role of the pharmacist in cancer care is definitely applicable to any field a clinical pharmacist would work, by being in the center of therapeutic decision making as the medication experts. So because I know that there's lots of people who might be watching this presentation or listening to the recording later on, and not everyone is from the same level of practice. So I'll start initially with doing some important introductions. So what is cancer therapy? So cancer therapy can be either surgery, can be radiotherapy, and the chemotherapy itself that we give to patients has different types. When we say neoadjuvant chemotherapy, that means referring to chemotherapy prior to surgery. So this is chemotherapy that's given to patients to reduce the tumor size to be able to conduct a surgery. Adjuvant chemotherapy, which is typically the chemotherapy given after surgery or radiotherapy, or metastatic and palliative chemotherapy, which is primarily the chemotherapy is given to patients who are at the end of life or nearing the end of life, just to help with the symptoms. Also, when we talk about immunotherapy and targeted therapy and hormonal therapy, immunotherapy is also one of the newer strategies for the management of cancer patients. And it's one of the methods that we use to give patients drugs to strengthen their immunity. And targeted therapy, where we give patients drugs that act on a particular receptor. And hormonal therapy, it's the use of drugs that act on certain hormones in our bodies, like androgens or estrogens. I might just switch to a presenter mode here. It'll be 1 second. Yeah. Is there any way that we can make this on the screen, Dr. Muhammad? I'll just continue with this format. So chemotherapy was first administered in 1941 when Goodman and Gilman gave nitrogen mustard to patients with lymphoma. This was the first time people heard about chemotherapy, and with some success in treating those patients. And most chemotherapy agents generally target rapidly proliferating cells, both normal and cancer cells, and these agents might act at one or more phases of the cell cycle. And the chemotherapy, we usually use a few different agents at the same time as part of a chemotherapy protocol. This is very important, and we'll talk about it later on. But basically, patients, when they receive their cancer treatments, it's very important that the chemotherapy is based on a particular protocol, that it's evidence-based. What is the aim of the cancer treatment? In the most part, we would like to always, as much as possible, aim for cure or survival. And obviously, that's not always possible to cure patients, but we always, particularly for cancers that are approached in treatment early on, we can usually treat patients aggressively, on time, with full doses and to the schedule. We will often go ahead with the treatment despite some toxicity. So when we're aiming for a cure, we will always like to give the chemotherapy as quickly as possible, on time with the full dose, and we would like to always go ahead despite some toxicities. Obviously, there are some toxicities that may delay the treatment, but when we're aiming for cure, we always like to treat patients as aggressively as possible, but also with balancing the toxicity. Another aim of cancer treatment is remission. We would like to always increase in remission. We would aiming for increasing survival and lifespan. We're not aiming for a cure, but we're rather aiming to produce a long period of remission. And with regards to cancer treatment in the metastatic and the palliative treatment, particularly for patients at the end of life, we usually give them small doses of chemotherapy or reduced doses of chemotherapy. And the main goal of the treatment is not cure, but rather to help reduce the pain and the symptoms of cancer and improve the quality of life that's left for the patient. Now, the chemotherapy cycle, chemotherapy agents are typically given in a defined repeating cycle that's called a cycle. So we give patients chemotherapy every 3 weeks, every 4 weeks, once a week, according to that chemotherapy protocol. And the cycle length typically depends on the toxicities associated with the chemotherapy agents in order to allow sufficient time between cycles so that the patient can have enough time to recover from the toxicities, example, neutropenia. And really, the number of cycles will depend on the treatment goals, whether it's curative or palliative, prior clinical trials, the stage of the disease, whether it's early or advanced, and the treatment response and the tolerability. How do we dose chemotherapy agents? This is very important. We usually use body surface area, and we usually use either Mostella or Dubai formula. And I've put here for you the Mostella formula, which is the height times weight divided by 3600 and then square root all this. That's the Mostella formula that we use for the calculation of the BSA, where chemotherapy protocols are based on body surface area. Obviously, people working in cancer will be very familiar with the calculation of body surface area. Sometimes we'd use a weight-based dosing, so a milligram per kilo, or a fixed flat dosing, for example, drugs like pembrolizumab and vincristine. We also use area under the curve calculation for drugs like carboplatin using the Calvert formula. Now, what I'm going to talk about in the next couple of slides is very important. Evidence-based protocols for cancer treatment is very important. The use of evidence-based protocols, example, the ones available from the Cancer Institute of New South Wales, Australia, or from the Canadian BC Cancer Agency, or the American NCCN guidelines, is essential in cancer care. We need to be able to provide details of the cancer therapy, including supportive care, admin instructions, and dose reductions. These protocols need to be very clear, evidence-based, so that clinicians, including doctors, nursing staff, and pharmacists, are familiar with the doses of the drugs in the protocol and that it's based on evidence. Also, it really helps reduce non-evidence-based variation and help standardize practice. Now, I've put a link here for an example of a protocol that I would like you all to click on that link and have a look at the eviQ protocol. I put an example of a colorectal metastatic chemotherapy protocol. It's very commonly used, called FOLFOX6, which is a very common protocol to use for patients with colorectal cancer. And you'll see all the instructions about the doses, the dose reductions, the drug administration, just to make sure that patients are managed in the best possible way. Now, the evidence-based protocol in cancer care, as I said, is very important. It's very important there's a very clear, explicit documentation of the relevant protocol details available to practitioners at the points of prescribing, dispensing, and administration of chemotherapy. It's very important that we have the name of the intended chemotherapy protocol, and it's clearly and explicitly documented on the chemotherapy medication chart, and all individual cytotoxic agents are prescribed in accordance with the named protocol for each specific day of the cycle. It is really important that the patient's body surface area or height and weight are also recorded with the medication order, and the final prescribed doses of the cytotoxic medicines are within the safe range based on the patient's BSA and protocol guidelines. So having a fixed evidence-based protocol that has the details of all the treatment, all the doses, the name and the intention of the chemotherapy, the details of the patient, is very important to make sure that we're giving chemotherapy safely to our patients. Also, monitoring of chemotherapy and dose modifications is very important, and healthcare professionals, including physicians and nursing staff administering the drugs, should monitor all the clinical and laboratory values affected by a specific anti-cancer agent at baseline and periodically during treatment. For example, a complete blood count should be evaluated weekly or prior to each cycle whilst receiving chemotherapy agents associated with myelosuppression, and monitoring of neutrophil count, blood count, and platelet count. In addition, a chemistry panel is needed to assess the organ function, renal and hepatic, especially for agents eliminated or metabolized via those routes. So when we evaluating the chemotherapy of the patients, we need to make sure that we refer to the protocol and the patient bloods, including kidney function, liver function, blood tests before we administer the dose of chemotherapy. This is an example of dose modifications in accordance to the eviQ guidelines, which is the Australian guidelines. And as you can see here, it's very clearly documented what to do with each of the cutoff treatments for the blood tests, platelets, renal impairment, and hepatic impairment. So that this provides very clear guidance for clinicians and nursing staff when they're administering chemotherapy for the patients. The importance of having the standardized approach and also having very clear documentation of what the cutoff is paramount to the treatment of our patients and making sure that we improve patient outcomes. Now, in the next part of the presentation, I'll be talking about the hematopoietic stem cell transplantation. This is a very specialized field in the management of patients undergoing transplantations, particularly for hematological malignancies. So what is transplant? What is the hematopoietic stem cell transplantation? It is the process of replacing diseased or damaged marrow with healthy and functioning marrow. This was initially pioneered by Thomas and colleagues in the 1970s and really advances in infection prophylaxis, tissue typing, blood banking, and graft versus host prophylaxis. And by the way, graft versus host refers to rejection, which is what happens in transplant. But in bone marrow transplant or the hematopoietic stem cell transplantation, we call rejection graft versus host disease. So the advances in graft versus host prophylaxis has really made bone marrow transplant a viable and effective treatment modality for a variety of diseases. Now, transplant is a procedure that is usually used to give very high doses of chemotherapy. That's called conditioning chemotherapy or conditioning regimens to patients with blood cancers like lymphoma, leukemia, and multiple myeloma. And the conditioning regimen is followed by infusion of stem cells. If we're using the patient's own stem cells, it's called autologous stem cell transplant. And if you're using a donor stem cells, it's called allogeneic stem cell transplantation. Now, when do we use autologous versus allogeneic stem cell transplantation? In principle, the risk of relapse is higher with autologous stem cell transplantation, and that's primarily due to the fact that we're using the patient's own stem cells. So the risk of the disease coming back is higher. On the other side, the chances of cure is higher with allogeneic stem cell transplantation because we're using a donor stem cell. However, the risk of treatment-related mortality is significantly lower in the autologous transplant as compared to the allogeneic stem cell transplantation, so 1 to 5% versus 10 to 20%, and that is primarily because of the risk of graft versus host, which happens primarily with the allogeneic stem cell transplantation. The autologous stem cell transplantation has definitely become safer over the last decade with an average treatment-related mortality of only 1% in some specialist centers. Now, both autologous and allogeneic stem cell transplantation have become very well-established therapeutic options for a variety of hematological malignancies, particularly for patients in remission but are at risk of relapse and patients with relapsed or refractory disease. So what are the diseases that are currently treated with autologous stem cell, with hematopoietic stem cell transplantation? Hematological malignancies like acute myeloid leukemia, chronic myeloid leukemia, non-Hodgkin's lymphoma, and multiple myeloma. Non-malignant hematological disorders like sickle cell anemia and aplastic anemia, solid tumors like testicular cancer, and immunological diseases like scleroderma and multiple sclerosis. But with immunological diseases, only very few specialist centers around the world perform transplants for autoimmune diseases, but it is in fact very successful in selected patient population. So what are the sources of stem cells? How do we get the stem cells? So if the stem cells are coming from the patient, they're called autologous. If they're coming from an identical twin, they're called syngeneic. And if they're coming from a donor, they're called allogeneic from another. Now, in terms of allogeneic, there is a sibling transplant. So from for example, a sister or brother, or a matched unrelated donor, or a matched umbilical cord blood unit, or from a mismatched related or unrelated haplotransplant. Now, what are the type of stem cells? The type of stem cells that we use in transplantation, the first one is bone marrow stem cells, and they're usually associated with less chronic graft versus host, but they take longer to engraft, which means more risk of infections. When the cells take longer to engraft, that means neutropenia goes for longer, and there's definitely more risk for infection. Peripheral blood stem cells are easier to obtain, but are a lot quicker to engraft, and hence there's definitely less risk of infections. I've just put this slide to highlight the importance and the differences between the different donors sources in adult stem cell transplant. Just to highlight primarily the sibling transplant and the matched unrelated donor transplants, mainly the unrelated adult donor transplants, they're the gold standards of the transplant, because basically they have the best outcomes in terms of having less graft versus host disease. In terms of the umbilical cord and the HLA haplo-related transplantation, there's definitely more risks in terms of infection and more increased risk of graft versus host disease. So when we choose conditioning chemotherapy regimens for patients undergoing transplants, we usually combine this with chemotherapy and plus or minus radiotherapy. The two main types of transplants, there's the myeloablative transplant, which basically given very big doses of chemotherapy to patients, and there's the reduced intensity conditioning transplants. Generally speaking, the myeloablative transplant is generally reserved for younger patients, less than 50 years, and the reduced intensity conditioning are generally speaking reserved for older patients, more than 50 years old. Those patients are heavily pre-treated. Reduced intensity transplantation has got what we call a graft versus leukemia or graft versus lymphoma effect, which is very useful in patients above the age of 50, because we're not giving the full doses of chemotherapy, but on the other hand, we're trying to use graft versus host disease to our advantage in helping with curing the patients. So I've just put some examples from what I'm talking to you about the use of chemotherapy on eviQ. So this is an example of the use of conditioning chemotherapy, and this is example of one of the protocols that we have on the website, on the Australian eviQ website, which basically stipulates the exact doses of chemotherapy and also the days of the treatment and when the patients should be getting them. Now, these protocols, as I mentioned before, will have very specific guidelines on how to give the drugs, how to administer the drugs, also the side effects, the drug administration requirements, particularly for nursing staff who are giving the treatment. And this is another example of an allogeneic reduced intensity conditioning protocol, fludarabine and melphalan. Again, the doses are very stipulated here, is very well clearly documented, and the days of the chemotherapy of the patients. Now, I'm going to touch briefly on graft versus host disease, because I think this is one of the most important complications of transplant. Basically, graft versus host disease is the transplantation rejection, or as we call in Arabic, rafd. Means the patient who are undergoing a transplant, they're at risk of rejection if we don't give drugs to reduce their immune system. Now, generally speaking, we only need graft versus host prophylaxis in patients having transplant from a donor. Obviously, if someone is having a transplant from their own cells, we don't need to give them graft versus host prophylaxis, because these patients are already using their own stem cells. And so patients who are undergoing transplant for allogeneic stem cell transplant, we definitely need to give them drugs to reduce their immunity. And that would be done pre and post stem cell infusion. And the different drugs that we use will be definitely depending on the type of transplant, the source of stem cells, patient factors, and disease factors. This is a just to show you a pie chart, just to show you the causes of death in the first year after transplant from an Australian New Zealand data between 1992 and 2001. As you can see here, relapse and graft versus host disease are definitely the most significant part contributing to deaths in our patients. And graft versus host disease is by far the most common complications of allogeneic stem cell transplantation. Now, the classification of graft versus host disease, initially they used to classify it as either acute which is before day 100 after transplantation, or chronic if it happens after day 100 of transplantation. The acute graft-versus-host disease usually comes in the form of red skin rash, a gastrointestinal disease in liver, and the chronic usually would occur in the skin, eyes, mouth, GI tract, liver, lung, and genitals. However, in the new classification of graft-versus-host disease, there is definitely the classic acute graft-versus-host and the classic chronic graft-versus-host, but there tends to be an overlap between chronic and acute graft-versus-host before and after day 100. Now, the ideal agent that we use to help prevent graft-versus-host disease, we would like to ideally to cause the death of the alloreactive or host-reactive donor lymphocytes, which causes the graft-versus-host. And we would like to leave behind the unharmed donor T cells, which has memory for pathogens, which is very important for the recovery of the immune system. And we would like to increase the T regulatory cells. This is obviously an ideal situation, but it often what we're seeing is that we still get a lot of the host-reactive donor lymphocytes, which can cause a graft-versus-host disease. Now, these slides highlight the very important development of graft-versus-host disease agents along the years, beginning from 1960 until in the 2000s. Initially, we'd only have methotrexate between 1960 and 1970, and when cyclosporin was introduced in the late 70s, and they started combining both methotrexate and cyclosporin, has definitely became a game changer for our patients and has started improving survival and reducing the rate of graft-versus-host disease. And in the 1990s, with the introduction of tacrolimus with methotrexate and also mycophenolate, definitely has helped a lot with the treatment of graft-versus-host, and the introduction of what we call post-transplant cyclophosphamide with sirolimus and tacrolimus as well has completely changed the picture and has allowed also for patients to undergo mismatched transplants as well. This is an example from the eviQ website. What I'm trying to do through my presentation, I'm just trying to highlight the importance of having protocols that are published and available on a website that can be accessed freely by clinicians and by practicing doctors and nursing staff and pharmacists to be able to highlight the doses of drugs that we use. Also be very important to highlight the standardization of practice so that everyone is doing the same thing and also following the methodology of transplantation and chemotherapy safely. I think I'm going to skip the antithymocyte globulin because it's a very subspecialized new agent that we use in the transplant. And at the end, I'll leave my details for specialist cancer pharmacists who would like to ask about the incorporation of antithymocyte globulin within the transplantation. But it's suffice to say that the use of drugs like antithymocyte globulin has reduced the rates of chronic and acute graft-versus-host disease dramatically. That has allowed us to do more complex transplant, which translated to better patient outcomes. So I'm just going to skip through those presentations, but as I said, I'm more than happy to coordinate with people and liaise with everyone who's got questions about the use of ATG for graft-versus-host prophylaxis in patients undergoing transplant. How do we treat graft-versus-host? So we spoke before about the prophylaxis of graft-versus-host. What happens if we have a patient with graft-versus-host disease? Again, the answer is prednisone. Yes, the all-time eating, shaking, bone thinning, weight gaining, everything bad making, so you can never sleep again medicine. It's definitely still the best agent that we have to treat graft-versus-host disease. So prednisone and giving steroids in patients who develop graft-versus-host disease is definitely one of the better approaches that we have right now to help control graft-versus-host disease. And we generally use very big doses of methylprednisolone in patients who develop graft-versus-host disease, up to 2 milligrams per kilogram per day. Now, obviously, and this is something that it's very evident in cancer treatments, when we give patients immunosuppressive treatments like methylprednisolone or cyclosporin or tacrolimus, that increases the risk of infections. So it's a very fine balance when you treat patients with graft-versus-host to give them the right immune suppression without causing major infection. But also, it is very important at the same time to give patient infection prophylaxis to make sure that patients can be managed safely. And only about 60% of patients do respond to systemic steroids. And again, if patients do not respond to steroids, we do have other agents, but they're not as good as steroids for the first-line treatment of graft-versus-host disease. I've just put here some photos for patients with acute graft-versus-host disease to show you the intensity of this disease and the intensity of transplant rejection that patients can experience, which can be life-threatening. This is a photo of a patient with acute graft-versus-host disease that that was provided to me by one of my colleagues at St. Vincent Hospital. And as you can see here from the photos and from the skin is really damaged. And the skin is the first line of defense against a lot of infections. And if it is affected, these patients can unfortunately develop a lot of infections. Now, I'm not going to go in detail about the second-line therapy of acute graft-versus-host disease, but suffice to say the least that patients who fail 5 to 7 days worth of initial treatment of methylprednisolone, we call them steroid refractory, they generally have very small and very poor survival rates of up to 20-30% after 1 year. And the agents that we use only provide minimal response up to 50% maximum. Agents like methotrexate and mycophenolate and alemtuzumab and ATG, they do provide effect, but unfortunately they come at the cost of putting the patients at more risk of infections. Now, I'm going to talk about the next part of my presentation, about the management of chemotherapy-induced neutropenia. This particular part of the presentation applies for patients who are undergoing cancer treatments in general. So patients undergoing treatments for breast cancer and any type of solid organ malignancy, hematology, and also transplants. Now, it's important that when we talk about chemotherapy-induced neutropenia, is to define neutropenia. Now, neutropenia is the decrease in the number of absolute neutrophil count to less than 0.5 times 10 to the power of 9 per liter, or less than 1 with a predicted decline to 0.5 over the next 48 hours. Now, febrile neutropenia is termed febrile neutropenia because, as the name suggests, it is neutropenia associated with a fever temperature of at least more than 38.3 on one occasion or more than 38 on 2 or more occasions. Now, chemotherapy-induced neutropenia is myelosuppression due to chemotherapy, which leads to the decrease and delayed production of neutrophils. Now, neutrophils are basically the first line of defense that we have within our white blood cell count in order to prevent infections. And when chemotherapy causes reduction and decrease and delayed production of neutrophils, that will definitely lead to the increase of infection. It is definitely a major dose-limiting toxicity of chemotherapy and often would require prolonged hospitalization and broad-spectrum antibiotic use. Now, as a result of broad-spectrum antibiotic use and hospitalization, this can cause delays and dose reduction of chemotherapy and potentially compromising clinical outcomes. And febrile neutropenia, as a result of chemotherapy-induced neutropenia, can occur up to 10 to 50% of patients with solid organ tumors and more than 80% in patients with hematological malignancies. Now, chemotherapy-induced neutropenia, along with the disruption of the mucosal barriers and inherent microbial shift and microfloral shift that accompany this severe illness, can predispose neutropenic patients to infections, and up to 60% of patients who are febrile will have an established infection. And in about 20% of patients who have a neutrophil count of less than 0.1 will develop a bloodstream infection, what we call sepsis. Now, what are the risk factors for febrile neutropenia? This is very important to understand, particularly for pharmacists managing patients undergoing chemotherapy. Now, older patients, so 65 years and older, are definitely at more risk of febrile neutropenia. Patients who have had previous chemotherapy or radiotherapy, patients who have poor performance status, patients with poor renal function, poor liver dysfunction, like, they have liver dysfunction, especially with elevated bilirubin, the depth of absolute neutrophil count within the first cycle, recent surgery, open wounds, and pre-existing neutropenia and bone marrow involvement with the tumor. What are the risk factors for poor clinical outcomes with febrile neutropenia? So patients who have neutropenic sepsis, which means they have a blood infection whilst in neutropenic, patients with more than 65 years of age, patients who have prolonged neutropenia, more than 10 days. And this is really important. You know, imagine a patient who have no neutrophil count for 2 or 3 weeks. These patients will be a very high risk of infections. Invasive fungal infection, pneumonia, and prior episodes of febrile neutropenia. So all of these are predictive of poor clinical outcomes with febrile neutropenia. Now, pathogens in febrile neutropenia, a considerable number of patients will have no infection etiology documented beforehand, but clinically documented infections can occur up to in 20 to 30% of the febrile episodes, and common sites of tissue-based infection include intestinal tract, lung, and skin. Now, bacteremia occur in about 10 to 20% of all patients, with most episodes occurring in the setting of prolonged and profound neutropenia. And mortality rates for critically ill patients have been reported at 10 to 20%, with rates for patients with gram-negative bacteremia up to as high as 40%. Now, common pathogens in febrile neutropenia, you know, early on during the febrile neutropenia, most bacterial infections that we see are gram-positive, like, you know, coagulase negative staph, streptococcus, and enterococcus, and gram-negative infections like E. coli, Klebsiella, Enterobacter, and Pseudomonas aeruginosa happen later on. Fungal infections, particularly Aspergillus, can develop later on, particularly during febrile neutropenia in patients with prolonged and severe neutropenia. So this is a diagram from the management of patients with febrile neutropenia, and this is the from the Australian Consensus Guidelines for Management of Neutropenic Fever. As you can see here, the point I wanted to highlight is that patients who have features of systemic compromise or very unwell, they really need to have the first dose of antibiotic within 30 minutes. Now, this is very important, and this is actually very well studied to show that it contributes and correlates with clinical outcomes. If patients are very unwell and have delayed administration of antibiotics, these patients would be at serious risk of dying and severe complications. Now, the MASCC index score is a score that we use for identifying low risks, for identifying low risk patients with neutropenic fever. The higher the number of the score, the better the outcomes for the patients. So as you can see here, if patients have no hypertension, they score high, a score of 5. If patients have no dehydration, they score up to 3 points. Patients less than 60 years, they score 2 points. So the higher the score, the better the outcome will be for patients. So it is very important to talk about these things, because as pharmacists and clinicians involved in the treatment of cancer patients, we really need to understand the risk factors and the prognostic factors that can contribute to making patients get better, or patients becoming quite unwell. Now, empiric antibiotic choice. Antibiotic selection may vary between different institutions based on local resistant patterns and antibiograms that help guide antibiotic choice. So that's why it's very important that we use antibiotics in the best possible way, and we don't waste using very broad spectrum antibiotics for all of our patients, and have a risk stratification strategy. Generally speaking, for patients with neutropenic fever, we usually use anti-pseudomonal beta-lactam antibiotics, like piperacillin and tazobactam, or kifopime as first line. And if patients have life-threatening penicillin or beta-lactam allergies, we usually use aztreonam or ciprofloxacin plus vancomycin. Now, aminoglycosides can be added if systemic compromise or if there's additional anti-pseudomonal cover is needed, and vancomycins definitely need to be considered if there is gram-positive cover needed, particularly for patients with infected lines like CVC and IVC lines. Cellulitis, patients who have features of cellulitis, and patients who are MRSA carriers with extensive skin breaks and mucositis. Metronidazole definitely can be considered for patients with features of abdominal or perianal infection. And piperacillin and tazobactam or meropenem, they usually have very good, adequate anaerobic cover. Now, modifications of empiric therapy can definitely be considered for patients who have no response to treatment after 3 days by addition of antibiotics like vancomycin, or there is a systemic compromise. And fever after persistent fever after 5 to 7 days, and there's culture and is negative, we definitely need to consider adding an antifungal agent and proceed with appropriate investigation like Aspergillus PCR, sinus imaging, or high resolution CT scan. How do we prevent febrile neutropenia? Now, we've understood that febrile neutropenia is a very significant can cause significant dose-limiting toxicity in our patients. How do we prevent febrile neutropenia? Now, the use of myeloid growth factors like filgrastim and pegfilgrastim and the use of prophylactic or use of G-CSF has definitely shown to reduce the incidence of severity and length of chemotherapy-induced neutropenia, particularly in patients with sarcoma, non-Hodgkin's lymphoma, and breast cancer. Meta-analysis has definitely confirmed the efficacy of G-CSF in decreasing the rates of infections and the risk of neutropenia in patients, and in particularly patients having aggressive chemotherapy for breast cancer and lymphoma. Dose-dense regimens supported by the use of G-CSF support definitely improve disease-free survival and overall survival as well. Now, in terms of prevention of febrile neutropenia, as we mentioned before you start treatment of patients, it's very important to assess the patient risk factors, and that's why it's very important to mention and understand the factors that we mentioned previously, and also assess the myelotoxicity of the individual chemotherapy regimens. And primary prophylaxis with G-CSF is recommended from the first cycle in patients who have a febrile neutropenia risk of more than 20%. And secondary prophylaxis should be considered for patients who experience neutropenic complications with prior cycles of chemotherapy. Now, should we use antibiotic prophylaxis for patients undergoing treatment to help prevent patients from getting febrile neutropenia? This is a very controversial issue. It's definitely been recommended in some guidelines to use fluoroquinolone antibiotics for prophylaxis of high-risk patients. However, the Australian Consensus Clinical Working Group have recommended that fluoroquinolone prophylaxis only be considered in very high-risk hematology patients. And this is primarily due to the failure of fluoroquinolone prophylaxis, so drugs like ciprofloxacin or norfloxacin, to demonstrate reduction in mortality, and also due to concerns promoting antimicrobial resistance. Now, I want to show you this slide. When you see a patient resistance panel comes back like this, that's not good. When you have a patient who's got Klebsiella pneumonia or E. coli and with basically antibiotics resistant to all antibiotics, cefotaxime, cefepime, Cipro, Gent, amikacin, and meropenem, that's not good, because the drugs that you have left to treat those patients are minimal. And that's why it's very important to exercise what we call antimicrobial stewardship, to make sure that we use antibiotics in the best possible way and we don't waste our antibiotics and obviously end up with quite bad resistance patterns. Now, I'm going to touch very briefly on antifungal prophylaxis on cancer care, because I think that's really important, and that would be leading to the end of the presentation. So antifungals, generally speaking, many invasive fungal infections are associated with poor prognosis. And generally speaking, before the availability of good antifungal agents, we were not able to perform transplants on patients, because these patients would have significant infections, particularly Aspergillus infections, and we were not able to treat them. But now that we have very good antifungals agents that we use to treat our patients, it is definitely has been very beneficial for our patients. As you can see here, some of the pathogens and mortality due to the invasive fungal infections, for example, like Candida, they have up to 40% overall mortality if a patient get a Candida infection whilst neutropenic. Aspergillus infections can have up to 62% mortality. Invasive molds up to 80%, and Scedosporium almost 100% mortality rate in patients who are neutropenic. Now, similar to the factors affecting antimicrobial prophylaxis, also the factors affecting the need for antifungal prophylaxis will depend on the patient population, the type of chemotherapy, the type of transplant you're performing, the incidence of invasive fungal infections at your treating center, environmental factors like building and construction work, and availability of diagnostic tests within a particular center. Now, what are the factors that we need to consider when choosing antifungal prophylaxis? The antifungal spectrum is very important to think about when we're choosing antifungals. The patient risk and the period of neutropenia, toxicity profile, drug interactions, need and the cost of therapeutic drug monitoring, the cost of drug, and the route of administration. The cost of drug is such an important factor. We obviously need to think about this because the more we use cost-effective drugs, the more we have drugs available for patients to use later on. Now, this is a slide to show you the different types of antifungal strategies that we use for patients undergoing treatments. Obviously, as you can see here from the overall antifungal risk, we start by low, and intermediate, and high. And you wouldn't want to be using broad spectrum antifungals for everyone. That's why it's very important, again, to use this risk stratification approach so that patients with low to intermediate risk, they get the right type of antifungals, and patients who really need the wide spectrum antifungals, who are very high risk of getting infections, particularly those patients who are having hematopoietic stem cell transplantation, or patients undergoing intensive chemotherapy for leukemias, they need to be considered for the wide spectrum antifungals. Now, therapeutic drug monitoring of antifungals is very important. Now, why is therapeutic drug monitoring important? And that can be applied to a lot of antifungals, a lot of antimicrobials, a lot of immunosuppressants. Now, really, we wanted to apply therapeutic drug monitoring to optimize the potential for a favorable patient outcome and minimize the potential for side effects. And most antibiotics, including antifungals, the activity of the agent is related to one of the following: the time that the serum concentration exceeds the minimum inhibitory concentration of an organism, so the time spent over MIC, the maximum serum concentration, Cmax to MIC ratio, and the area under the curve. These are the very important determinants for the activity of the agent and its effect on the patient. That's why therapeutic drug monitoring is essential for those agents that we have access to therapeutic drug monitoring. So what are other antimicrobial prophylaxis we use in cancer care? Pneumocystis jirovecii, which is used to be called Pneumocystis carinii. Prophylaxis is very important, particularly with high-risk patients. Toxoplasma prophylaxis, antiviral prophylaxis, and close CMV monitoring, which is monitoring for the cytomegalovirus, and monitoring the CR, the C-reactive protein, which is the CRP. So all of these antimicrobial prophylaxis strategies needs to be employed in patients with cancer care. Other supportive care, we need to always maximize our anti-nausea and antiemetics by the use of drugs like 5-HT3 receptor antagonists like polonocetrone and dancetrone, the NK1 receptor antagonist like aprepitant, and dopamine antagonist, very well known like metoclopramide and domperidone, and others that we use like cyclizine, lorazepam, olanzapine, and prochlorpromazine. Pain relief, from a pain relief point of view, we get a lot of patients who develop mucositis, which basically the inflammation of the mucosal tract. And that's why it's very important to treat those patients and give them the appropriate pain relief. That's the other supportive care that we always consider in patients undergoing hematopoietic stem cell transplantation. Now, the dose modification with chemotherapy toxicity, and this is one of the things that I'm going to be starting to work on as part of the Cancer Institute project, is that dose adjustments of chemotherapy should be based on toxicities, comorbidities, treatment intent, renal function, and liver function. And all the above should be done independently of the obesity status. And this is very important because a lot of centers, they tend to sometimes give patients who are obese reduced doses of chemotherapy, but actually evidence suggests that these patients need to be treated appropriately according to their weight. There obviously are certain drugs that we can use ideal body weight or adjusted body weight for, but the majority of drugs we need to give the appropriate doses according to the patient actual weight. Common side effects of stem cell transplantation that we've discussed. So immune suppression, definitely increased risk of infections, graft versus host disease, nausea, vomiting, mucositis, veno-occlusive disease, which basically development of clotting in the patient's blood vessels and liver, which can be quite detrimental and can lead to quite poor patient outcomes. Renal hepatic impairment from the use of drugs, and definitely prolonged neutropenia and pancytopenias that patient can encounter. Now, I do have a case study at the end, but considering that we have ran out of time and we're approaching the 50 minutes mark, I would like to stop here. What I would like you to do is that for people who are actually interested in this particular presentation, have a look at the case study. And I put a case study for you to work on based on what we've discussed in the lecture. I know there's obviously a lot of information to go through, so that's why I've left the case at the end. I'd like you to go through the content, have a look at the case, and I have put some information about the management of the patient in that particular case, which is a real case from my practice, and also put some information about management of drug interactions, particularly the azole and calcineurin inhibitors drug interactions, and I'm hoping that this will be very beneficial to you. So at the end of the presentation, I put some important resources. I just wanted to highlight, I'm maybe a bit biased because I work in Australia, but eviQ is definitely an Australian government, one of the best resources that are freely available for clinicians, and it's definitely a very good resource for cancer treatment protocols. It's developed by multidisciplinary teams and cancer specialists with the goal to improve patient outcomes, reduce treatment variation. eviQ provides very good evidence-based information to support health professionals in delivery of cancer treatments and available at the time of treatment when decisions are being made. Also, I put links for the BC Cancer Agency, British Columbia Institute from Canada, provides a very comprehensive cancer control program in Canada. And I've also put the link for the National Comprehensive Cancer Network NCCN guidelines from the US, which is again a very useful resource for clinicians working in cancer. I'm not sure there'll be any questions, but I'm happy to take questions. I've also put my contact details, my email. I'm very happy and quite interested to have an open communication channel with pharmacists in Egypt, particularly those who work in the cancer setting or working in the area of bone marrow transplantations. I'll be very open for collaboration, sharing of information, making myself available for advice to help my colleagues in Egypt. Thank you for listening, and thank you again, Dr. Muhammad Izzat Amin and Alamein International University for the kind invitation, and thank you all.
Right، في النهاية بنشكر طبعا ضيفنا العزيز الدكتور كريم إبراهيم، وبنشكر حضراتكم for taking the time to attend. أنا عايز بس أنوه عشان لو أي حد بيتفرج على ده through a recording، إن شاء الله we'll try to upload this على موقع الجامعة إن شاء الله. ف please feel free، يعني الدكتور كريم كما أشار he's more than happy to help colleagues في مصر إن شاء الله to bring this to practice. This concludes our session. بنشكر حضراتكم جدا ونتمنى لكم إن شاء الله يوم سعيد.